Okay. So you guys as sonographers in whatever capacity, you mainly as okay will be dealing with or be a part of the radiology department. Okay. Okay. Now, as I used to say back in medical terms, radiology came from it's okay, what you can call the radio waves, or what we now that actually end up calling X-rays. Okay, okay. Why do they call it radiology? Mainly it's okay because that was the first imaging modality that was developed. So the first time that anybody was able to just okay get an image of just okay what the internal organs or what the inside of the body might look like on a picture was on an X-ray. Okay, okay. Ever since then, yes, okay, the things has been evolving. Okay, and mainly because the X-ray has the limitation of yes, okay, that you only get okay as a frontal view and a sagittal view, or frontal view or a lateral view. Okay, there was no transverse views. Okay, that's when that's okay. CAT scan came in. So what CAT scan gives you is more of a view along the axial view, or that's okay in transverse sections. Okay. And now the thing about CAT scans is that okay, still uses radiations. Okay, not just a little bit, but it's okay a lot of radiations. Okay, so that has its own. That has, as you can say, it's okay its own risks, etc., associated with that. Okay. Uh, then you may have heard something like okay that we call an MRI. Okay. Now, even back then, I told you guys, okay, what does MRI stands for? It stands for magnetic resonance imaging. Okay, so that big donut that they put you through, if you are okay undergoing an MRI, is actually it's okay a big piece of magnet. Okay, um, now there are going to be as okay certain structures which are going to be more clearly visible on an MRI that you can't see on a regular CAT scan. Forget about seeing it on an X-ray. Okay, so that's why it's okay for certain studies. It's okay, an MRI may be recommended or a CAT scan. Another thing about the MRI is that it actually gives us views in three different planes. You can get sagittal views, you can get transverse views, and you can get frontal views. Okay, did that make sense? Now, whether it is an X-ray, whether it is a CAT scan, whether it is an MRI, or even yes, okay, whether it is a ultrasound. Now, as I said yesterday, ultrasound, what that use, or sonography as we call it, what we use in that is sound waves. Okay, that little transducer thing that you actually is okay will be using is actually going to be built in a way that it converts the electrical energy into sound energy, which means okay, just propagates into the patient as sound waves and will reflect back. Yeah, okay. And then yes, okay, that's going to be yes, okay, reconverted back into electrical energy. But eventually, yes, okay, you get an image on your screen. Okay. How all that works, that's what we mean. Yes, okay, we'll talk more about later on in this module slightly. But yes, okay, the most detail of it is going to be in ultrasound physics. Okay. But even yes, okay, in all these modalities, yes, okay, what they may still use is contrast. Okay. Now, if you look at the word contrast, that means, yes, okay, it just means differentiating. Okay. So, uh, now, if you, for instance, yes, okay, uh, go for a CAT scan and they says, okay, it's going to be a CAT scan with contrast, or MRI with contrast, or even as, okay, they now also getting in ultrasounds. Okay. What is that contrast going to be? That's going to be a chemical substance that they may ask you to either drink or swallow, or most likely, yes, okay, will be given into the, or given to the patient intravenously, indirectly into the bloodstream. Okay. And what is that going to do? That's mainly going to, yes, okay, make the area in which the contrast is running, or which holds the contrast to be standing out, or be more, yes, okay, well defined or outlined from the neighboring organs or structures. Okay. So if there's something that you, for instance, swallow, yes, okay, you will see, yes, okay, a good solid outline of the stomach as a contrast in the stomach, and then it runs through, yes, okay, and the intestine. You can see that. Okay. If it's something that the patient may, yes, okay, be given intravenously, yes, okay, first it may go into the bloodstream. So you actually will see, yes, okay, a good solid outline of the blood vessels, because they're going to be, yes, okay, pretty much, okay, like yesterday we say, highlighting the text. So here it's going to pretty much, okay, highlight out the outlines of the blood vessels. And it will be relatively easy to, you can say it's okay, identify any occlusions, obstructions, blockages, etc., in the blood flow. Okay. Or we can say it's okay, identify the area of lesion. Okay. Did you guys get that?
I have a question.
Yes.
Is contrast needed when scanning the heart, or is it just like for CT
And
scans?
no, they may even use contrast, for the heart.
Oh, okay.
Okay. Okay. So uh, because it's okay to look at the blood flow areas, okay, through the chambers of the heart, or more importantly, through the coronary arteries. Okay. Did that make sense, dear? Okay. But my dear, when you go to the heart, well, okay, there are different ways in which, yes, okay, the contrast may be given. They may give it, yes, okay, intravenously, and mean, yes, okay, put the patient tick, 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 through a scanner, which means, yes, okay, just going to make what we used to call a film or a movie. Okay. Uh, Sometimes, yes, okay, when they go for, yes, okay, what we can call, yes, okay, PCI, percutaneous intervention, usually when they go through the groin, all the way, yes, okay, through the, pretty much, okay, yes, through the arteries up to the heart. And from there, yes, okay, they may, yes, okay, through that um, cannula, as you may call it, or tubing, actually, yes, okay, inject contrast through that. And at that point, yes, okay, record it. Okay. Did that make sense? Okay. But even ultrasound or sonography, yes, okay, that comes under what we can call as, okay, the radiology department. Now, mainly because other modalities which doesn't involve what we call as, okay, the traditional x-rays, like an MRI, uh, like your sonography, for instance. That's why it's okay, they're pretty much, okay, sliding off from the term called radiology to diagnostic imaging. Okay. And that's it's okay, pretty much, okay, what these imaging modalities here are about, to just, okay, create an image of the structures, and mainly as, okay, look for possible abnormalities that may, as, okay, help in either confirming or excluding a diagnosis. Okay, so the image diagnosis is mainly going to be based on the imaging or image findings. Okay, now who is going to be painting those pictures? That'll be you guys. Or you can say, okay, taking those pictures. Did that make sense? Okay, so you just need to know, that's okay. Primary, that's okay. You need to know, that's okay, when to click the button. When you say, okay, this is the best selfie. Okay, okay. That shows, okay, yes, what was required as per the protocols, and okay, yes, I'm ideal, yes, okay, I've been able to catch the lesion or the pathology. Okay. Any questions, guys? Jesus. Okay. Now, what do you expect? Or how do you think it's okay a work day is, or let's say it's okay. What will be the first thing you do when you see the patient?
Introduce yourself.
Okay. How would you like to introduce yourself, my dear?
Hi, my name is Cassidy. I'll be your ultrasound tech today.
Exactly. Okay. You don't give out your last names. Okay, guys? Your last name is your title. Clear? Okay. 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 How would you know that you are talking to the right person? There's a waiting room, 15 people are sitting in that waiting room waiting for their turn.
Confirm their name.
You may walk, okay. How?
Well, if they do a test at the hospital, they usually give them a band. So it would be helpful to look at the band versus your records.
Mm-hmm.
And also in some doctor's offices, don't they leave the patient chart outside of the room so you can check?
Yeah, but that's when somebody already had called the patient in, right?
Oh, okay, okay.
Maybe you can say something like, can you please confirm your name and date of birth for me?
Exactly. Okay. It would be more correct to ask the person to confirm his or her name. Okay, because most likely, yes, okay, the patient maybe you can say, okay, caught off guard. And you say, okay, Peter Nilsson or something like that. And he go, yeah. He may not be Peter Nilsson. His name may be something else. Okay. And you think that you're talking to Peter Nilsson, but okay, yes. And it's a completely different patient. Okay. So the best thing would be that's okay that you ask them to verify their name. Okay. And in many places, it's okay, they go not just with the name, but also it's okay the birthday. Okay. Okay. And but nowadays, it's okay. It's getting more and more. You can say it's okay, foolproof because it's okay. Everybody is okay as if they walk in. Most places now, it's okay. Give a bracelet. So even it's okay if, but even then, it's okay. Though the scan, the barcode or whatsoever on the bracelet is going to be as okay. It will still be as okay. A good practice of still verifying is this still the right patient? Okay. Okay. And there's nothing wrong of saying us asking the patient his or her name. That's okay. Is this your name? Are you really Peter or are you somebody else? Okay. But I'll still say that's okay. The best way to do it is to ask them to say their name. Okay. Of course, that's okay. The patient is in coma or something like that, or if the patient is sedated and you're standing there, okay, he has to verify his name. right? Okay, verbally, well, that's not going to happen. Clear? Okay, okay. So, but as long as okay, as the things, for instance, okay, or the bracelet, for instance, okay, are scanned, yes, okay. Because you may have, yes, okay, unfortunate situations where, yes, okay, the identity of the person is still known or it's not known. He or she may be just as okay, initially as okay, just identify as okay as an off serial number or something like that. Until yes, okay, we get the information on who this person is, or we establish his or her real identity. Right, okay. Good. So you had the patient in. What will be next?
Vital signs and history.
Okay, good. Okay. Now, most likely, yes, okay. Yeah, vital sign. Okay, we talk about those in a little bit. Okay. Now, when you say history, most likely, yes, okay, as far as your history or the history that you guys will be taking is, okay, what's the current issue? What brought you in today? Okay. Did that make sense? Okay. Most likely nowadays, that's okay. The patient union is okay before they are called in. That's okay, filled out, okay, it's a questionnaire, right? That means it's okay. What procedures have you undergone, etc., 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 etc. Okay. Some procedures may leave okay as a big or a small visible scar, and based on yes, okay, the location of that scar, etc., etc., you may yes, okay, be able to say, okay, this scar is probably from this procedure, that's so and so and so. Okay. So which may give you a clue as okay what to expect when scanning the patient. Okay, but mainly it's okay what brought you in, what are the main complaints. Now, two things that okay as people confuse. Now, there's something known as a symptom, and there's something known as a sign. Okay, usually it's okay just because it sounds, as I call it, okay, chick. People will go signs and symptoms. Okay, but the way in which it is going to be collected is going to be the other way around. It's first going to be the symptoms. Now, what do you mean by symptoms? Does anybody have any idea what a symptom is?
It's like what you're feeling, like if someone says I'm nauseous or I have a headache, it's a symptom.
Exactly. Okay. Okay. So maybe that's okay. What you can call is okay. The patient's main complaints. That's going to be his or her symptoms. Okay. You can say it's okay. I'm nauseous. I have a headache. I have blurry vision. Okay, ringing of the ears. Okay, lower backache, pain in the belly. Okay, yes, exactly. All those things can be symptoms. Okay. Now the next would be signs. Okay, SIGN. And if you want to plural, it's going to be NS at the end. Okay. Now signs, that's mainly going to be as okay, findings found on a clinical exam. Okay. Let's say it's okay, you've been coughing for the last 3 days. Okay. Okay. Light fever. Okay. Etc. Now, on a clinical exam, it's okay when they, for instance, okay, look in your throat, they look in your eyes, they may look at, okay, check your ears, they may, okay, listen to your lungs, your heart, etc., all those things. Those findings that they found during that, that's going to be signs. Okay. Okay. So they find that, okay, as your throat, for instance, okay, is swollen. Okay, there's some redness they may see as okay, something that looks like smaller, bigger, as okay, accumulations of pus, etc. That would be signs. Okay, they listen to your lungs, and okay, yes, there are some crackles and crepitations there. That will be a sign. They listen to your heart, they may hear, okay, it's a murmur or something like that. That will be signs. Okay. So that's okay. In a little bit, it's okay when we talk of vital signs is much going to be as okay signs. We say it's okay of vital functions of the body. Okay, mainly as okay, which, well, okay, yes, you can't live without. Okay. After that, well, okay, yes, there might have been lab results, lab tests. Okay, but signs and symptoms, that's mainly as okay, going to give you, or you can call a clinical diagnosis. Okay. Usually it's okay, you go to the doctor and they say, okay, well, okay, based on your history, based on our findings, this is what we think it is. Okay. They may suggest some other diagnoses as well and say, okay, it could be this, it could be this, it could be this, it could be this as well. Okay. Those, it could be this, it could be this, it could be this, those are going to be what we call a differential diagnosis. Okay. Now, how do we exclude those, or how do we confirm that it is or isn't our primary diagnosis? You can say it's okay, lab tests. So lab test, that will be a diagnostic procedure. EKG, that will be a diagnostic procedure. Okay. Sonography or CAT scans or X-rays, those are diagnostic procedures. Did that make sense? Okay. Okay. Now, what are they going to do? Either confirm or opposite, that okay, yes, the primary diagnosis wasn't the right one. Yeah, okay. So that's meaning, yes, okay, we had to go for a hunt on, yes, okay, the actual diagnosis. Did you guys get that? So okay, that's fine. Okay. I'll say yes, okay, we're done with chapter 1. A lot of these details, that's okay, is going to be brought up again and again and again and again. Okay, now guys, let's take a short 10 minutes break. And when we come back, it's okay, we'll get to chapter, or we'll take, okay, a big leap onto chapter number 10. Okay, let me just see if I need to find some things as well. Okay. Okay, guys.
Okay, thank you.
Okay, you're welcome. Good. So we're going to start talking about what we can call vital signs. Okay. And now before that's okay, so yes, okay, we must, as sonographer, be able to, yes, okay, monitor or yes, okay, take what we can call vital signs. Now, what I mean, yes, okay, just said before the break was any finding on a patient which involves, yes, okay, a big or smaller procedure, yes, okay, will be referred to as signs. Okay. Okay. So redness of the throat, you can say it's okay. Okay. Redness of the eyes. Okay. pain. And now please keep in mind, guys, that pain, that's going to be a symptom. The patient will say, I got pain here, I got pain here. Okay. Whereas pain that is elicited by, let's say, it's okay, touch. Or touching, that is what you call tenderness. Okay. So tenderness in different areas, that's okay. Those will be signs. Okay. Okay. So vital signs are mainly as okay going to be signs, mainly as okay going to be findings found on okay as not really a clinical examination, but which is because it's vital for a clinical examination. But what these vital signs is okay are all about is mainly as okay monitoring the vital functions of the body. Okay, okay, and ensuring that okay the vital functions of the body is okay are is okay optimal. Okay, because without these functions here of the vital, that's okay, that are going to be as okay recorded as the vital signs, that's okay, the person will not be alive. Okay, and you can mainly see okay, see that as okay as we go talk about the vital signs. Okay, so the first one is going to be the body temperature. Okay, now you may all know that okay, as long as you are alive, or you can say it's okay that your heart is pumping blood. Okay, not only is that going to maintain that what we call homeostasis, but as a result of that, that's also going to keep the body warm. Okay, and mainly it's okay how warm or hot or cold the body may be. Yes, okay, that's going to be measured by the temperature. Okay, or by measuring the temperature. So that's why it's okay. That gives us okay clue about yes, okay, our vital signs. Pulse. Now, if you guys remember from our anatomy physiology, I said that which blood vessels will have a pulse was going to be an artery. So primarily as okay, except from one pulse. That's not going to be from an artery, but if you feel a pulse, that pulse most likely is going to be because or felt because you have your fingers on top of an artery. Okay, and how is that pulse going to be felt as? A slight tap on your fingers. Okay, what are going to be different clues that we will get from a pulse? Yes, okay, that's what's going to be, or that's going to be, yes, okay, what we will be talking about. Okay, but out of yes, okay, all the pulses that I will be mentioning to you guys, all of them except one will be a arterial pulse. Okay, now what does it mean to be an arterial pulse? That's a pulse felt in the arteries. Okay, did that make sense? Okay, clear? Okay, so if you feel a pulse, that mainly means okay, you have your fingers on an artery. Okay, now I'm going to just okay change the word feel. Feel is a regular English word. Okay, what would be technically is okay or in clinical science use as an alternative word for feeling is going to be palpate or palpation. 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 Okay, so I may say palpate this and that pulse. That may mean that okay, you will use your fingers to feel that pulse. Okay, by English, we will call feel. In technical and clinical terms, we call it palpation. Okay, so anything that you can feel with your fingers is going to be okay to palpate. You can say it's okay, palpate a lymph node. Okay, palpate is okay as swelling in the neck. Okay, things like that. Okay, so anything that you can register by is okay, the sense of feeling. Most likely with your fingers or with your hand, that's going to be okay palpation. So the primary method by which it's okay we feel a pulse is by palpating. Did you guys get that? Okay, and I can still spell it out for you guys. It's going to be PALPATE, palpate, or PALPATION, palpation. Did you guys get that? Now be watchful, because if I say PALPATION, what did that become? PALPITION.
Palpation?
Huh?
Palpation?
Nope. PALPITION.
Palpitation?
Palpitation. And what is a palpitation?
Is it like when it does an extra beat? Like the heart.
Okay.
Mm.
That could be one reason. But mainly it's okay when the patient feels that his heart is okay, yes, beating fast or forcefully. Okay, so that's going to be okay what you will refer to as a palpitation. Now the reason that I wrote it, I gave you the word palpitation here, though it doesn't have much to do with palpation. But it's mainly just a matter of taking 2 letters out or putting 2 letters in, and the thing changes, right? Okay, so my point here is be watchful for words where the beginning and end looks alike, because there's going to be something in the middle that's going to make a hell of a difference between the two. Clear? Okay. So you may know that, yes, to feel for something using, your fingertip or fingertips is called palpation. But because you are in a rush on a test, you may choose palpitation. Okay. Did that make sense? So there's a hell of a difference between palpating something and having a palpitation. Okay, if you try to palpate for something and you can't feel it, that may give you palpitations, but that's a different story. Okay, dear. Okay, so yes, be watchful for similar words that may in the beginning and end look alike. So just as a little extra point. Respiration. Okay. Now, what was respiration? Mainly as taking a breath in and out. Okay. Mainly as a couple of things that we will be looking for as in respiration is how many times does the patient breathe? What is the nature of his or her breathing. Okay, but why is it that, okay, respiration is a vital sign? Mainly because, okay, that's pretty much the way by which the body, or the blood, sorry, gets rid of the carbon dioxide. So it gets reloaded with fresh oxygen that then can be provided to the body tissues, okay, which is going to be, okay, vital for the body tissues to perform their functions. The last but not the least is going to be, okay, what we will call a blood pressure. Okay. Now, ladies and the gentlemen, there's going to be, okay, oh shit, there's going to be, okay, different ways of, you can say, it's okay, defining a blood pressure. Okay, we can go with a simple way, and we can give you, I can even give you guys the literal bookish definition of a blood pressure. Okay, but mainly, as okay, what we'll come down to is, are you guys going to be able to, yes, okay, take a blood pressure? Okay. Now, I know most of you will say, well, okay, in the hospitals and the clinics, here and there, etc., etc. Well, okay, yes, it's those automatic blood pressure cuffs that they use. Yes, I know that. But in schools, those are not allowed. Okay, so you will still have to, yes, okay, learn how to take a regular blood pressure using, yes, okay, the, what we now, yes, okay, can call, yes, okay, the old days piece of equipment. Okay, which will include, yes, okay, a sphygmomanometer and a stethoscope. Okay, did you guys get that? Here, yes, okay, the nurses that you see, the medical assistants that you see, the nursing assistants, etc., etc. They, yes, okay, in the clinic, in the practice, at the workplace, yes, okay, may use those digital automatic, yes, okay, blood pressure equipments, but they have been through the same process. They still have to know how to take it the traditional way. Okay, and it's not that difficult. Okay, it's not that difficult. You just have to be able to, yes, okay, coordinate between what you see and what you hear. That's it. If you have a good coordination between those two things, okay, yes, it's going to be easy. Abish. Okay.
I had a quick question. Do we
Yes,
have
Maria.
to, I'm sorry, do we have to buy a, what does it cost?
No,
Oh, no?
no, you don't have to.
Okay.
Okay. If you want to, nobody is going to forbid you from doing it, but you don't have to buy it now. Okay.
Thank you.
And okay, no problem. Yeah. Anything else? Now, although you don't see it here, but some places may even, yes, okay, consider what we call an oximetry, a vital signs. Oh, yes, okay, one of the vital signs. Now, if you just look at the word oximetry, okay, it's going to be oxy, which means, yes, okay, it's going to be pertaining to your oxygen. And metry, since it ends with a Y, is going to be, yes, okay, the process, and meter is going to be measure. Okay. Have you ever wondered, yes, okay, if you go to a lab, clinic, yes, okay, God forbid, yes, okay, get transported in an ambulance, that little thing that they put on your finger. That's an oximetry. Primary, yes, okay, two things that it may do is give you, yes, okay, or record, yes, okay, the oxygen level in your blood. And most of them, sorry, they also, yes, okay, give a heart rate. Or what we can call, yes, okay, a pulse rate. Did that make sense? Okay. So in some places, yes, okay, they may even, yes, okay, consider, yes, okay, or consider the pulse, oximetry as being a vital signs. Now, first and foremost, because my dear, okay, Michelle, then you may ask, okay, do we need to buy our own thermometers then? Body temperature, right? Okay. And that's going to be, that's okay. There's an array of thermometers. And what they all do is pretty much okay, the same. Okay. Their main job is, yes, okay, to measure the body temperature. Okay. So body temperature, what is that going to be? Yes, okay, I'm measuring on that, mainly going to be, yes, okay, the degree amount of heat that is produced within the body. Either, yes, okay, due to activities going on in the tissues, or and mainly, yes, okay, as a result of what you can call it, the circulation of blood. That's mainly going to, yes, okay, ideally, yes, okay, keep your body at an ideal temperature of, okay, a 78.9 degrees or 79.6 degrees Fahrenheit or 37 degrees Celsius or centigrades. Okay. Did you guys get that? Okay. Now, there may be, yes, okay, different areas in which, yes, okay, temperature can be taken. Okay. Now, the most common or, yes, okay, traditional areas where temperature could be taken would primarily be the mouth, the axilla, and yes, somebody may be scratching their heads, but rectal. Okay. And that's pretty much okay. Yes, these will be the areas where they will use traditional thermometers. Okay. Now, thermometers that we used to have back in the days when, okay, yes, I was growing up, were mercury thermometers. They probably, okay, I was taking those off the market, mainly because, okay, somebody, yes, okay, might accidentally, yes, okay, chewing it. And it's okay, the main body of the thermometer was made up of glass and that could break. And mercury is, well, okay, hazardous material, and that's why it's being taken out of a lot of things. Okay, the very traditional sphygmo manometer still will use as okay a film of mercury that will rise as the blood pressure rises, or we record a high blood pressure. But nowadays, okay, they are more and more being replaced by big bends or wheels where you actually just, okay, just have a point, pointing at a number. Okay. So primarily, as okay, orally, which is going to be as okay, the mouth. Axillary is okay in the armpit, or rectally is what you can call, yes, okay, the three, yes, okay, primary areas, yes, okay, where temperatures used to be taken with traditional thermometers. Now this just became digitalized. Okay. So they may, yes, okay, just going to give you a beep and okay, yes, you will read the number. Okay, in the old days, okay, thermometers you had to just okay look for how far okay as a thin film of mercury has risen, and looking at that could sometimes yes okay be a battle because that tube within the thermometer in which yes okay the mercury rise was okay as a thin tube thinner than a hair, and within that yes okay you should be able to yes okay locate to which level the temperature or that's okay the mercury has risen. Nowadays they even have okay that's what we can call as okay membrane thermometers. Clear? Okay. And you may see them yes okay more or less frequently used in practices. The forehead one, right? Okay. So that's what the me yes okay will call yes okay temporal thermometer. Okay. Or the tympanic, where they actually yes okay go in the ear, okay, with a thermometer. Now the last one, off the record, guys. I say it, but I still didn't say it. I don't believe in the tympanic thermometers. And why is that?
It can be inaccurate.
Pretty much because what you actually would have to do is that membrane on the tip of the thermometer actually has to go in and touch the eardrum. Okay, so how far is somebody going to be ready to just okay let that happen? Okay, so they are, you can say it's okay widely it's okay inaccurate. Okay, now out of this okay three traditional temperatures that we take: oral, axillary, and rectal. The actual body temperature is the rectal one, where you don't really have to add or subtract anything. Okay. Now somebody may say okay that temperature can actually yes okay increase because one of the patient parts as the temperature is being taken. Okay, that's going to cause us okay a sudden rise in the rectal temperature. Okay. But yes, okay, many places, yes, okay, they didn't believe in okay taking oral temperatures or axillary temperatures. But they would say, okay, well, okay, listen, buddy, turn over and roll them down, and okay, pretty much okay, yes, we'll go with a rectal temperature. Okay, but that's the one where it's okay, nothing needs to be subtracted or added on to. Any questions? Now, next time, yes, okay, now you may have second thoughts, right? Okay. Next time you go and they say, okay, well, you're going to take your temperature. And they say, okay, just open your mouth and you're going to say, I just want to make sure this thermometer hasn't been in somebody's. Okay. Now, usually it's okay if they do that, they're going to just okay cover the thermometer with a thermometer probe, which means yes, okay, it's going to be a covering. But even nowadays, it's okay, the oil temperature or thermometers, they will have okay as a single use probe cover. Okay, so no matter it's okay whether you put it in the mouth of somebody, whether you put it in the armpit of somebody or anywhere else, okay, the thermometer will not be functioning until and unless the probe is covered by what you can call a probe cover. Clear? Okay. Now, so we had okay as normal temperature. Clear? Okay. What was normal temperature? Yes, okay. We have the list of that. Okay. Where you can mainly say that, okay, yes, 98.6 degrees. Now, what may happen if the temperature falls? What would you call that? If somebody is colder than normal.
Hyperthermia.
Hypothermia, right? Okay. Right. So if somebody is colder than normal, that's okay. That will be hypothermia. Now, what can be common reasons for hypothermia?
Being in extremely cold climate.
Extremely cold water, weather, right? Okay. Good. Can hypothermia be deadly? Of course. Okay. The body is not, okay, the body temperature is not kept in the optimal range. Of course, that's okay. That's going to have its effect. Okay. So that's one thing. Now, on the other end, if your body temperature is greater than normal, what will you call that?
Hyperthermia? No?
No. Good guess, but no.
Hyperthermal.
Fever?
Fever. Okay. Now, fever, my dear, that's a good old traditional English word, right? Okay. Now, if a person has a fever, as you may call it, okay? How would you get that? Maybe it's okay because you see, or it's okay, based on your temperature reading. Okay, that it is about the normal range. Now you can say it's okay, maybe a low grade fever, maybe a high grade fever, etc. Okay, right. Did that make sense? Okay, but the traditional term for yes, okay, a fever is going to, you can say that the patient is going to be what we'll call febrile. Okay, Febrile, febrile. Okay, so the patient has febrillia, or he or she is febrile. Or we may say that he or she has pyrexia. Okay, now what does pyrexia mean? P-Y-R-X or P-R-Y-E-X-I-A.
That means fever, right? Pyrexia?
That's the condition of fever, yes. Okay, a state of fever.
Does it
But
mean
how did
fire?
it was, yes, exactly right. Okay, because back in the day, that's okay, they didn't have thermometers. Okay, they were made as okay, just feel the patient. So can you palpate a body temperature? Well, okay, you can feel whether the patient is hot or cold, but you will not be able to, yes, okay, say, okay, this patient has a fever of, okay, 102 or 103. You will just feel that, okay, he or she is hotter or colder. Okay, but the main reason is, okay, the main way that they call it is, okay, and they call it pyrexia is because the patient felt like he or she was hot as fire. Did that make sense? Okay, so that's okay from pyrec, that's okay from pyre, which actually means fire, P-Y-R-E, came the term pyrexia. Okay, which mainly is okay with me, or would be as okay a term used for as okay the condition of having a fever. Okay, so you can say as okay the patient has pyrexia, or he or she is pyrexic. which means will mean that okay, yes, he or she has a fever. Okay, or you can say the patient has fibrilia, which means will mean has a fever, or the patient is fibrilic. Did you guys get that?
Yeah.
Okay. Any questions? Okay, let me just ask then. What's going to be reason number one for a fever?
Illness? Sickness? A sickness?
Okay, what kind of sickness, my dear?
Um, a cold, a flu?
An infection?
Infection. Clear? Okay. So reason number one for a fever is infection. Okay. And once that's okay, that is confirmed that the patient has a fever, the next thing will just be, let's go for a search. That where is it that this infection here is that causes the fever. Clear? Okay. Did that make sense? Okay. Any questions? Now you can chalk off, okay, different areas, different infections, etc., etc. Tonsillitis, otitis media, meningitis, rhinitis, syphilitis. That's usually not a fever, that's more of an inflammation or infection. Okay. Okay. Gastritis. Usually it's okay, that's not really going to give you much of a fever. You're just going to be puking and throwing up or have okay, some pretty bad diarrhea. Okay. Bronchitis. Okay. Pneumonia. That's okay. Usually it's okay. The patient will have it's okay. Strong fevers. Okay. Or high fevers in pneumonia. Okay. And now just off the record, guys. No, you guys are not going to be as okay administrating medications to the patients. That's not going to be your job. Okay. But off the record, if somebody has a fever or a temperature of more than 102 degrees Fahrenheit, before giving them, yes, okay, Tylenol or so and so, what should be done?
Check their blood pressure, maybe? Because aren't you not supposed to give them
No,
something?
no. Right. Okay, my dear. What I'm talking about right now is of managing the fever.
Oh. Fluids?
Huh?
Give them fluids?
Okay.
Would you maybe try to cool them down?
Cool them down. So that's what you call is okay, those cold compressors, right?
Yeah.
Okay. Or you mean it says okay, take as much clothing off as possible. Okay. And cool them down. How? Mainly as okay with cold water. Yes, okay. Towel is being yes, okay, soaked in cold water and place that on as okay as much skin surface as possible. And that's going to yes, okay, pretty much okay, cause the heat to radiate. And you'll feel that okay, that towel with water, which a couple of minutes was cold, is now warm. Okay. And why is that? because it's okay, a temperature above is okay, 102 degrees. The child now is not going to be able to bring it down. Okay. Another thing is, okay, yes, if the temperature is that high, it may most likely go further up. And at a level of a temperature of 104, is okay, even the brain's temperature center, or what you can call it, okay, the thermostat in the brain may not properly work. So even yes, okay, that goes cuckoo. And that's not what you want to happen. Did you guys get that? Okay. So a temperature more than 102 degrees Fahrenheit, do cold compresses. Okay. Good. Of course, yes, okay. Now, what will be the body's normal response of, okay, as trying to cool the body down?
Sweating.
Sweating. Okay. Okay. And of course, yes, okay, if your temperature is so high that you actually, that the patient actually is okay, may sweat profusely to try to, okay, bring the temperature down. What's going to happen? You lose a lot of fluid in that sweating, right? Clear? Okay. And that's why you can say it's okay, fluid replacement. That you make sure that, okay, as you replace that lost fluid by consuming fluids. Right, Vicky? Was that what you were talking about?
Well,
Okay. Now,
thinking like
you
an
can say,
IV,
okay,
but
okay. Pardon me?
no, I didn't say anything.
Okay. I think you said something about an IV.
Yeah, that's what I meant. Like give them an IV or water.
Yeah,
Drink.
okay. IVs is only as okay. Ideally, it's okay only if the patient is really dehydrated, or is okay, or may not be able to, you can say it's okay, retain the fluid. They drink it, and okay, it's before you see or look around, blah, it comes out again. Okay. Now you can say things such as, okay, as sweating, things such as vomiting, things such as diarrhea, for instance. You can consider those as okay as visible loss of fluids. Okay. You can say, okay, well, okay, there's a lot of sweating. Okay. But one thing that, okay, is going to be, okay, an invisible loss of fluid. Whether you have a fever or not, but of course, that's okay, fever is going to be more profusely, or as okay, more extensive, is through your breath. Okay. So, yes, okay, fever is just okay, you may even have, okay, more loss of fluid in the breath, in your breath. But that's going to be, okay, what we call a non-sense loss. Okay, that you don't really sense it. You don't say, okay, okay, here went, okay, it's 2 cc's of water, of fluid in my breath. Okay. But things such as sweating, throwing up, or you can say, and it's okay, diarrhea, loose motions. That's more of, okay, as visible or sensible losses of fluid. Okay. What if somebody is hypothermic? What can be done?
You can try to insulate them with blankets, and they'll probably be shivering to try to warm themselves up.
Okay. Of course, my idea is, okay, the shivering part, that's going to be, you can say, it's okay, the body's normal response. Right, okay. Now, what? Okay, but I is okay. Try to is okay. Warm them up. Okay.
You can also do warm lavage with the fluids as well, right? That's another
Yeah,
thing. I do
yeah.
sometimes.
If it's well, okay, you can worry that's okay that they may bring it to not to actual body temperature, but actually that's okay. Not infuse what you can call hot or warm fluids, but that's okay. Something that is or relatively closer to regular body temperature, that's okay. May also is okay. Bring the temperature up. But as far as warming of the patient or warming up of the patient, it shouldn't be going, yes, okay, too aggressively. Okay, so there's actually is okay certain, I guess there's okay degrees of temperature that by which yes, okay, the body should be warmed up per yes, okay, per hour or so and so. Right? Now, one of the main reasons that occurs hypothermia, and especially is okay people who where there's a certain fall in the temperature. Okay, usually it's okay if somebody walks on thin ice and the next thing they know, the ice breaks and okay, as they drop into the lake or something like that, or ice cold water. Okay, or Jack on Titanic. Is going to be as okay as sudden hypothermia. And one of the things that happens in that is that actually is okay damage to the muscles, your body muscles. And that mainly is okay will lead to is okay release of a substance called myoglobin, the protein in the muscles into the bloodstream. And what that myoglobin may do is clog or clot the bloodstream or blood vessels. And it's okay in that way, reduce the blood supply to body tissues. Any questions, guys? Nope. Okay, guys. Now the next is going to be pulse. Okay. Now what is a pulse? Now what we mainly can say is okay, the pulse is means okay going to be felt on an artery. And that's why I said arteries have pulses. Okay. But we mainly is okay, we'll say what actually causes that's okay a pulse to be created in the artery actually is okay as a result of the beating heart. Did you guys get that? So, and watch my words, guys. Ideally speaking, every time your heart completes a beat, you should be able to feel a pulse. Did that make sense? So for each heartbeat, ideally speaking, yes, okay, you should be able to feel a pulse. Okay. Now, where that pulse is going to be felt? In the arteries. Okay, so did that make sense? Okay, and in the body, that are going to be as okay different areas where, yes, okay, a pulse can be felt. Okay, which all of them except one is going to be an arterial pulse. Because you can only call a pulse an arterial pulse if it is felt or palpated if your fingers is on top of an artery. Did that make sense? Okay. But what mainly happens as the heartbeat, or we can mainly says, okay, in this case, it's okay, goes into systole. What will happen? Blood is being pumped from, most likely we talk about the systole of the ventricles. Okay, guys? Okay. It's going to be pumped from the ventricles into the arteries. Okay. For this case, yes, okay, we are going to, yes, okay, not talk about the right ventricle. Because the arteries that we feel mainly is going to be, yes, okay, as a result of the contraction of the left ventricle. Clear? Okay. That means, okay, pumps a bigger or smaller bulk of blood into the arteries. And as that blood flows through the arteries, it's going to cause the arteries to expand. And feeling a pulse is actually, okay, feeling that expansion of the artery. Did that make any sense? Now, guys, just to make sure that, okay, let me see, do they have that? Oh, okay, good. That's good. Good. So let's just look at them here, guys, together. So here are, yes, okay, a couple of pulses. And here are some of the other pulses. Okay. Now, E. Now, I know, yes, okay, that he here is, okay, standing with the stethoscope. But pretty much, okay, in this area here on the chest, what is it that you feel? You feel a pulse. And what did I mean by a pulse? That tap. But mainly, yes, okay, because you feel it when, yes, okay, your hands are on the apex of the heart. This is going to be an apical pulse. And please mind it, guys, that is mainly, yes, okay, just the pulse that you feel by the beating of the heart. So your apical pulse is not an arterial pulse. Did I make myself clear? Okay, so if you feel the apical pulse, that is not going to be an arterial pulse. It's just the pulsing of the heart. The apical pulse is not an arterial pulse. Did you guys get that? And usually it's okay when we say one thing 3 times, it's for a reason. Yep. So I hope you know what that reason is. So please mind it, guys. Apical pulse is not an arterial pulse. I know, yes, okay, he's standing here with the stethoscope, but it's okay, you, yes, okay, with the tips of your finger, placing it. If your heart is beating strong enough, yes, okay, you may feel a pulse. Now, this one here is a traditional one. Okay, 99.9% of the instances, yes, okay, if a pulse is meant to be felt, it's going to be, yes, okay, on the radial artery. So this is going to be a radial pulse. Or mainly you can say, now please, yes, okay, guys, this is going to be the line of my thumb right here. If you remember your blood vessels, radial pulse was on the lateral side, right? From the radial artery. Okay, so 99.9% of the instances, okay, if somebody wants to check on your pulse, this would be the fellow here. Okay, and I can feel mine right here. Yes, okay, it's pounding like anything. Okay, now just on the other side over here is another artery. And what do you call this artery then? On the medial side?
Ulnar artery.
Ulnar artery. So this is going to be an I can feel it right here. Right here. If this was the radial artery that gave you, yes, okay, what you can call a radial pulse, then if this is the ulnar artery, then this is going to give you an
Ulnar pulse.
ulnar pulse. Clear? Okay. And there's no doubt about it that, okay, yes, since you feel the pulse, that's because your fingers were on top of the artery. Clear? Okay. Did you guys get that? Now, this one here is, okay, a little bit of a nightmare one. Okay, but what they mean is, okay, try to feel, is okay, behind the knee is going to be, is okay, the artery that we have behind the knee, which is going to be the popliteal artery. So that's going to be a popliteal pulse. Okay, now this one here is, okay, maybe it's, okay, a slight, because it's, okay, difficult one to palpate. Okay, relatively, yes, okay, the popliteal artery is going to be easy to scan. When you do, yes, okay, scanning of your lower limb. Okay, because it means, okay, just have to follow the femoral artery, and, okay, as behind the knee becomes the popliteal artery. But even here, it's okay, they, yes, okay, may find, yes, okay, try to feel for the pulse, and that's going to be a popliteal pulse. Okay, so whenever we say pulse, except from the apex, there's no question about it. They're just going to be referred to or named in accordance to the artery. This one here. Okay. Now, strange enough, as, okay, although it's, okay, it's right in between, yes, okay, you can say it's, okay, the ear and your jaw. Okay. Okay. But this is what you call, yes, okay, a temporal pulse. Okay. So, right here. Okay. Usually it's, okay, it's a small artery. So that's going to cause, okay, the pulse is going to be very, very weak. Okay, it's not going to be every person in which, yes, okay, you'll be able to feel it. Okay, but it is possible to, yes, okay, feel what you can call a temporal pulse. And some people, yes, okay, maybe more pronounced up here, but we call it temporal. Or lay people will call it temporal. Although this bone here is, what is this bone called?
Your sphenoid?
the sphenoid bone. Okay. So you may as okay feel a pulse up here, okay, or here. Okay. So that's going to be as okay your temporal pulse. Okay, mainly because temporal artery. This one here now you may not recognize, but I think it's okay if this is the upper thigh. Okay, I mean it's okay, chlorine is okay, the genitalia here, but this is going to be a femoral pulse. So pretty much okay, it's on the groin. And this area is okay, that was already as okay called the femoral triangle. So right here is okay, is going to be the femoral pulse as a part of okay, as your or as okay, by feeling or having your fingers on top of the femoral artery. Did you guys get that? Okay, let's look at this fellow here. Now this is going to be as okay, checking on what we call the dorsalis pedis. Now what I told you guys the other day when we were doing anatomy physiology was that that's going to as okay be felt mainly as okay in the line between as okay your first and second metacarpal, where that meets with the talus bone. This is okay, this big bone here is okay of your carpal bones. So pretty much okay in the line between is okay the metacarpal from the big toe and okay as that from the second toe. Okay. Okay. Where that meets with the talus bone, that's going to be as okay where you'll find the dorsalis pedis artery. Did you guys get that? Next is this one here. Now you can see this is the medial side of the foot. What we have here was what we call the medial malleolus. Okay, or we can see yes, okay, down here in his ankle. This is going to be yes, okay, where the medial malleolus is going to be. And right behind that, or we can mean is okay, right behind the medial malleolus or between the medial malleolus and what we have down here is going to be as okay, the Achilles tendon, sorry. That's going to be as okay where you'll find the pulse, which will be the posterior tibial pulse. Or what we can call it, okay, pulse of the posterior tibialis. Okay, and these two pulses here is okay, whether it's the dorsalis pedis and or is okay, the posterior tibialis are mainly going to is okay, what we call the distal pulses of the leg. Okay, so they may also be as okay, collectively as okay, referred to as the distal pulses of the leg. Last but not the least is going to be as okay, this one here. Okay, and okay, you may realize that okay, this is the patient's shoulder, this is his upper arm, and this is going to be the forearm. Okay, so right in this area is okay, this diamond-shaped area is okay in front of the elbow, which we'll call the antecubital fossa or antecubital area. Okay, but pretty much okay as anterior medial to that is going to be as okay the main artery of your upper arm pulse is going to be felt here, which is going to be your brachial pulse. Okay, or if you look here, anterior surface of my elbow on the medial side, and right here is going to be the brachial artery, and the brachial artery is okay when you feel that chap, 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 as I can feel right now. It's beautiful. It's going to be as okay. Me actually is okay, just feeling the brachial pulse. Did you guys get that? Okay, so pulses or arterial pulses, as we may call them, are mainly as okay, just going to be named in accordance to the artery that in which they are felt. Did you guys get that? Okay, and out of all the pulses that we talked about or mentioned, they were all arterial pulses except from the apical pulse, which was produced by the apex of the heart, or felt at the apex of the heart. Any questions? Now, a couple of things, guys. What do we get from the pulse? Now, what I said earlier was, ideally, each heartbeat should produce a pulse. Okay, that you may feel a bigger or smaller or lighter or stronger chap of the arteries expanding against your fingertip, and you feel the pulse. Okay. Now, if you still say that, okay, yes, it is ideal that each heartbeat should produce a pulse, that would mainly mean that, okay, yes, your pulse rate, which is going to be what we call the number of pulses felt in a minute, should be the same as your heart rate, which was going to be what we call the number of heartbeats per minute, right? Did you guys get that? Okay. Now, back in the days, we said, okay, what was the normal heart rate? 60 to 70 beats, 60 to 100 beats per minute, sorry. Okay, so if 60 to 7 beats per minute was your normal heart rate, and we say that ideally speaking, yes, okay, each heartbeat should produce a pulse, that, okay, the normal heart pulse rate should also be no more than, oh, yes, okay, should range between 60 to 100 pulses per minute. Did you guys get that? Okay, so pretty much, okay, yes, ideally speaking, yes, okay, feeling a pulse and counting, yes, okay, how many times do I feel a pulse in a minute? But ideal tell us, okay, how fast or slow is it that the heart is beating? So by, yes, okay, checking on the pulse rate, you'll be able to somehow, yes, okay, determine the heart rate. Okay. Now, if the pulse that you count is less than 60 per minute, you can say that's probably because the heart is beating at a rate less than 60 beats per minute. So you still call that patient being as okay a case of bradycardia, because low pulse rate mostly indicate a low heart rate, which we call bradycardia. How low? Less than the normal, which is 60 per minute. Did that make any sense? Now, on the other hand, if the heart rate, or if you feel more than 100 pulses in a minute, you count and you end up counting more than 100 pulses per minute. Wow, it's okay. Mainly mean is that but the patient's heart is beating at a rate greater than 100 beats per minute. So a pulse rate greater than 100 beats per minute or pulses per minute would indicate a heart rate greater than 100 beats per minute, known as bradycardia. So you didn't touch the patient's heart, but just by feeling the pulse, you were able to say whether his or her heart was beating slow or within the normal speed limits or fast. Did you guys get that?
I have a question.
Yes,
If you're taking someone's pulse,
Mhm.
is the calculation it's with it like the beats in 15 seconds times 4 if you're feeling on it?
We coming to that one in just a sec, dear.
Okay.
Okay. Any questions besides that? Okay. So yes, Susie.
Yeah, so when taking like the pulse, does it change, like, will it change if the patient has a pacemaker?
Now, my dear, what a pacemaker mainly is going to do is maintaining the normal pace of the heart. Clear? Okay. So most pacemakers, my dear, will only kick in case that the patient's heart starts to beat slower than normal.
Okay, I understand. Thank you.
Right, okay. Just think of as what was it that the heart, or what was it that made the heart beats? Those electrical signals, right? Okay. Now, if there's problem in that conduction pathway, that's okay. That may mean that as a signal which was produced at one point, it didn't make it to the ventricles. So you may not have much of a ventricular contraction and so on. So, right. So if the pacemaker mainly senses that, that's going to be when the pacemaker, or we can call it an artificial pacemaker or electrical pacemaker, is going to send out a electrical signal, and that's actually going to stimulate the myocardium and cause it to contract. Did you get that?
Yes, I did. Thank you.
Now, and that's why I say cardiology is a very musical subject. Okay, now we talked about rate. Normal rate was 60 to 100. Okay, a low rate of the pulse, which means ideally will indicate the same rate as that of the heart. If that is less than 60, will be bradycardia. Greater than 100 will be tachycardia. Okay. Now, you can say I be able to count, let's say from 1 to 110 in a minute. If I go 1, 2, 3, 4, 5, 6, okay, once a minute over, you say stop. I say, well, I was able to count to 110. Similar is if your heart was able to beat 110 times in that minute. Okay, of course that would be tachycardia. Okay, so that means determined or determined by the rate. So heart rate is going to be how many heartbeats in a minute, which ideally is should be the same as your pulse rate, which is going to be how many taps of the pulse did you feel in a minute? Did you guys get that? Now, another thing that we may get from a pulse is going to be what we call the rhythm. Now, those of you who like to listen to music, what do you understand by the rhythm? Yes, guys, what do you understand by the rhythm?
Like the sound that it makes.
Okay, the sound that it makes, that's going to be the music. That music may have a rhythm or it may not have a rhythm. Okay.
The beat.
Okay.
The pattern.
It's related. Pardon.
The pattern.
That's more like it. Just think of it this way, guys. A musical band or group, and there's a drummer. Now you just, okay, why would I use the example of a drummer? Because he or she is going to be beating the drum, right? And it mainly says, okay, every time dum 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 dum, he beats the drum, you're going to just, okay, hear the sound of the drum, right? Okay, okay. Now, based on the way that he beats the drum, he is okay may maintain a rhythm, or he or she may not maintain the rhythm. Okay, okay. Now you can say, it's okay, a rhythm may go like something like this: dum 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 dum. Now, what did that sound like? You could pretty much say it's okay. It sounds like okay that there was a regular time span between beat to 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 beat. Okay, so based on it's okay that pattern as area chat, or you can say okay the time span between beat to beat, beat to beat, beat to beat, beat to beat, that determines the rhythm. Okay, now that is the same if it go like dum 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 like that. You can mainly say that, okay, your rhythm is going to be regular. Did that make sense? So if the interval, so the time between beat to beat, beat to beat, beat to beat, beat to beat, beat to beat is the same, you can say about, okay, the rhythm is regular. Did you guys get that? Now let's go into, yes, okay, let's go back to our drummer and say that, okay, yes, the crowd is cheering, the waves are high, etc., etc., etc. And he may be carried away, not physically, but I don't know, it's okay, musically, yes, okay, by the cheers of the crowd. Okay, the blooming moves and whatsoever, and go, okay, and so wow, what a combination. But what did he do? He broke the rhythm, right? Because his regular rhythm was dang, 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 dang. Okay, so another form of okay as rhythm could be as okay irregular rhythm, where you meaning can say is okay that the interval between the beats, beat 1 to 2, 2 to 3, 3 to 4, 4 to 5, 5 to 6, is not the same. Did that make sense? So you feel a pulse that went okay, tap 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 tap, 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 tap. Okay, you can say, well, okay, it is not regular. Okay, okay. Or you have an irregular rhythm. Okay, now irregular rhythm of the pulse, most likely, yes, okay, will identify or indicate that the heart is beating at an irregular rhythm as well, right? Did that make sense? Did that make any sense? Okay, so what would you call that? That would be an irregular rhythm or irregular pulse. Okay, now that irregular rhythm or irregular pulse can also be referred to as an arrhythmia or dysrhythmia. Arrhythmia mainly means, okay, no rhythm. Where you can say, okay, a bad rhythm is, or irregular rhythm is, just like no rhythm. Or dysrhythmia, bad rhythm. Okay, did you guys get that? So if your rhythm is irregular, that's okay. That can mainly be referred to as a dysrhythmia or arrhythmia. Yes, okay, we talk about is okay, the arrhythmia or dysrhythmia of the pulse. But what that most likely is okay will indicate that the heart is also beating irregularly. Did that make sense? So mainly it's okay by having your fingers on the pulse. Ideally, it's okay, you will know how the heart is beating. How fast or slow it is beating, that's going to be the rate. And the rhythm. Is it beating regularly or is it beating irregularly? Now, Justine, I come to your question. Okay? Because the question then will be, now for how long is it that I have to just, okay, be standing there, let's say, okay, holding the patient's hand, etc., etc., etc. Okay, and it's okay feeling his pulse. Now that's mainly going to be based on if his or her pulse was regular or irregular. Did that make sense? Now what they mainly say is that, okay, yes, if you find that the patient has a regular pulse, or we can say, okay, that the pulse has a regular rhythm, which means, yes, okay, we're fine based on, okay, yes, is the interval between beat to beat to beat to beat or pulse to pulse to pulse to pulse to pulse the same? It'll be enough to count those pulses for 15 seconds and multiply that number by 4. Did that make sense? Did that make sense? Okay, so you feel that the pulse is regular or the rhythm is regular, it will be sufficient to palpate the pulse for 15 seconds. Not just feel it, but then you need to count, well, okay, how many pulses did I feel in 15 seconds? Whatever number you got, multiply that by 4. If you are not good at multiplying by 4, then just feel for half a second, or half a minute, sorry, or 30 seconds, and then just double that number. Okay. If you don't know how to double numbers, then okay, yes, there's probably no way out, but then you have to feel for 1 minute. Okay. Any questions? Now, if the pulse is irregular, then what do you need to do? Scooby-Doo, what do we do? If the pulse was irregular, that yes. How would you give me the heart rate for this patient here? Then there's no way around, guys. You have to feel for at least 1 minute to determine how many times did the heart beat in a minute. Did that make sense? So if the rhythm is irregular, you have to count for a full minute to determine the pulse rate, which ideally speaking should be equal to that of your heart rate. Did you guys get that? So the 2 R's of, yes, okay, cardiology, rate and rhythm. Yes, okay, they may walk hand in hand. Now, does anybody have any questions? Okay. Next thing, guys, we can say is, okay, the nature of pulse. Nature of pulse. And some of you guys will be saying, okay, what's left? Didn't we talk about rate? Didn't we talk about rhythm? What do you mean by this? Okay, the nature of pulse. Okay, guys. And that's what you don't find in your book. That's why I'm here. Because, okay, guys, listen. When you feel a pulse, where did that pulse come from? Or what causes that pulse?
The blood pumping through your veins or your arteries.
Okay. And when we say it's okay, coming to the arteries, where did that blood come from?
The heart.
The heart. Yeah, okay. So nature of pulse. Now, in some people, you may feel, yes, okay, a good solid tap. Dum, 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 dum. So you can say, it's okay, that's going to be a strong pulse. Right? What may that tell you? That this person here is okay when his heart or ventricle pump, a good amount of blood is being pumped out into the arteries with that heartbeat. Okay, so he or she had a good, yes, here we are. What do you call the amount of blood pumped by the heart in a beat?
The volumes?
Which volume, my dear?
What is it called? Like a cardiac output volume? I don't remember.
Exactly. But what do we call the amount of blood pumped by the heart in a single beat?
Blood pressure?
Nope.
Stroke volume?
Stroke volume is when you multiply that stroke volume by the heart rate, you get the cardiac output, right? Which would just be as okay, the amount of blood pumped by the heart in a minute. Lauren, Cassidy, and Kim, you may be exempted from some of these questions here for now. Okay. Okay. So if you feel, yes, okay, a good strong pulse, what does that tell you? That you probably have a good solid stroke volume, right? That with each heartbeat, the heart pumps, okay, as a good bulk of blood into the arteries, which is going to cause the arteries to expand well enough for us to feel a good solid tap. Did you guys get that? So bias, okay, you haven't looked at the patient's heart yet, but just from the pulse. Oh, yes, okay, as I may say, it's okay. The nature of the findings on the pulse, yes, okay, it may give you, yes, okay, a lot of clues about the heart. Did that make sense? Right? Now, what's going to be the other extreme? Because, okay, you may have, okay, as a strong pulse. The other opposite of strong is going to be as, okay, a weak pulse. Or a weak pulse as, okay, may even be referred to as a steady pulse. So you at some point as, okay, may come across the term steady pulse, which means, okay, we just mean a weak pulse. And what's a weak pulse going to be? It's going to be as, okay, hard to feel. But just think of it in that way. What would that mean? That the heart is really not pumping out enough blood per contraction or per beat that is going to be as okay enough to produce a strong enough pulse. So you have a pulse, but instead of as okay feeling like a tap, it's just going to be a vibration. Did that make sense? So what would that tell you? That most likely as okay, your stroke volume will be low. And if the stroke volume is low, it's okay. Ultimately, it's okay, the cardiac output will be low as well. Okay. Now, usual cases is okay where you feel, yes, okay, or what you have, okay, is what you can call a weak pulse or a steady pulse. Is most likely going to be, it's okay when a patient is in shock. And then you can talk about, okay, what will be the reasons for shock? There can be some cardiac reasons, something going on with the heart. So that would be, okay, what you call cardiogenic shock. Okay. You may not be able to feel, okay, a good solid pulse because the patient might have lost a huge amount of blood due to severe bleeding. So he or she goes into shock, which is due to blood loss. So you call that a hemorrhagic shock. Okay. Growing up, having diarrhea, okay, things like that, okay, or being dehydrated in one way or the other. It's okay. The patient may not be able to maintain a sustainable blood pressure. Or in this case, if you can say, okay, a good enough strong pulse. So that would be hypovolemic shock. Okay. Patients may go into shock as a result of a fever or infection. Septic shock. Anybody allergic to penicillin? Good. So here we go. Now, without disclosing your name, what will happen if, yes, okay, somebody gave you penicillin?
My throat would close up.
Okay,
Go into
that's what
shock.
you feel. Huh?
And I would go into shock.
Okay, now that specific kind of shock, especially as a result of a severe allergy, is what we call an anaphylactic shock. Okay. Some people may be super sensitive to penicillin. Some people may be super sensitive to bee venom or bee stings. They got stung by a bee. Before they start crying, they're already in shock. Okay. So those kind of shocks is going to be what you call an anaphylactic shock. But what mainly happens in whatever kind of shock you may talk about is mainly that there's going to be a sudden drop in the blood flow. Mainly the patient will not be able to maintain a sustainable blood pressure. But usually when you feel a weak pulse or thready pulse, what would that tell you about the heart? Or what would that tell you about your circulation of blood? Something is rotten. Yeah, okay. So it was not only just the rate and the rhythm, but also the nature. Do you have a good strong pulse? Okay, if that's the case, good. Or do you have a weak pulse or a thready pulse? Okay. And then you question it. Then the next thing will be, okay, what caused the patient to have this weak pulse here? Is it because he or she lost a great amount of fluids? Is it because of, something wrong with the heart? Etc., etc., etc. Any questions? Oh, wow.
I got my gown too.
Okay, facciamo la scuola. It's she's graduating from high school, so
Oh, congrats.
Congrats.
okay, thank you, dear. Okay. Okay. Now, ever since we start talking about pulse, okay, ever since we start talking about pulse, I said that ideally the pulse rate should be the same as that of your heart rate, right? Clear? Okay, now I know this is not written in your book, or at least not now, on this chapter here. But, okay, now, that's ideal. But will there be instances where the heart rate, which is going to be as, okay, how many beats the heart produces in a minute, and the pulse rate is going, okay, which is going to be as, okay, how many pulses are counted in a minute, may not tally with one another or will not be equal. Can we have those kind of scenarios where the pulse rate and heart rate are not the same?
Yes.
Yes. Of course we can. Okay. Now, what do we refer that to? Or what are we going to just, okay, call that scenario? Where your heart rate and your pulse rate is not the same. That is going to be referred to as a pulse deficit. So pulse, like the regular pulse, P-U-L-S-E, deficit, D-E-F-I-C-I-T. Okay. So it can be referred to as a pulse deficit or a pulses deficit. Okay. Where you just put a US after the pulse. So pulses, P-U-L-S-U-S, pulses, deficit or pulse deficit. Both the same thing, okay? Now, what the is that? What will a pulse deficit be? Now we made as, okay, said that, okay, yes, that there's a difference between the heart rate and the pulse rate, which may mean as, okay, one will be greater than the other will be lesser than the other. Did that make sense? Clear? Okay. Now, pulse deficit, guys, is mainly going to be when the heart rate is greater than the pulse rate. That will be referred to as a pulse deficit. Okay, so instances, that's okay, where you may say, okay, the heart beats at, let's say, 90 beats per minute, but our pulse was 82. So in this case, as you may be scratching your head and say, what happened to those 8 missing heartbeats? Or those 8 heartbeats where we didn't feel a pulse? That's pulse deficit. Okay. Now, just think of it as, okay, as I said from the beginning, because ladies and the gentlemen, there's a very common logical explanation or basic explanation to just, okay, what might have gone wrong here. And just think of it in that, okay, yes, that those 8 heartbeats where we didn't feel a coordinating pulse were not strong enough to pump enough blood into the arteries and cause them to expand enough to produce a palpable pulse. Did that make sense? Okay. Usually it's okay. We may find it's okay, things like that in yes, valve defects. Okay, and most likely it's okay, the big valves that leads blood from the heart into the blood vessels. So aortic valve. Okay, that the heart, yes, okay, or the ventricles, yes, okay, made a contraction, but that contraction did not lead into the, you can say, okay, projection of blood from the chambers into the blood vessels. So the heart does a job of says, okay, contracting, but it didn't pump blood into the vessels. And since it didn't pump enough blood into the vessels, the vessel does not expand well enough to, yes, okay, produce that somehow, yes, okay, good, solid, palpable pulse. Okay. So there will be, yes, okay, instances where the heart rate and the pulse rate will not be tallying or equal. Okay, and when we call it pulses deficit or pulse deficit, that's because you are deficient on the pulse side. Okay. Did you guys get that? So when the heart rate is greater than the pulse rate, that will be referred to as the pulse deficit. Now, of course, yes, okay, that will mainly require that, okay, yes, you listen to the heart or palpate the apical pulse if you are able to do so, and any, yes, okay, arterial pulse at the same time. Okay, but it's probably going to be easier to just, okay, listen to the heart and it's okay, palpate a pulse and see, okay, does every tally with a pulse being felt. Did you guys get that? Anybody? Anybody want to say anything? So what's the stroke volume?
The amount of blood pumped in a single heartbeat.
Single heartbeat. Okay. How much was an average stroke volume in an adult human person?
How many what?
What's the normal stroke volume in an adult human person?
Wasn't it 72? Or was it 5? I remember it was 50 something, 72 by 504, something like that. Those were the
No,
numbers,
it was
right?
70 cc's.
5 liters.
No. 5 liters, that become your cardiac output, my dear. So you can mainly say, okay, your whole blood volume is going to be pumped out in a minute. Okay. But in a normal adult human person, we will mainly say that, okay, the normal stroke volume is going to be 70 cc. That will mainly mean that with each heartbeat, 70 cc's or a little bit more than 2 ounces of blood is going to be pumped by the heart. Okay. 2 cc's, that will make up 60, 2 ounces, sorry, will make up 60 cc's, roughly speaking. Okay. So if you guys don't know what as 60 cc's are, that's is going to be equal to 2 ounces of fluid in this case here. Okay. So a little bit more than that would be 70 cc's or 70 mLs. But if everything is well, heart beating is at a normal rate, with a normal stroke volume, that's what they say is in an adult human person, the cardiac output is going to be 5 liters, approximately 5 liters in 1 minute. And that's the average amount of blood that an adult human person has. Any questions? Now, guys, it may sound strange, but if you divide your blood volume into 3 parts, or 3 equal volumes, at all time, 2/3 of that is going to be in the veins. And just 1/3 is going to be in the arteries as the circle goes on. Now, which organs in your body will get the most blood from the arterial supply? Well, let's say it's systemic arterial supply. Now, if it's in the arterial supply, it's we can divide it into 3 parts, 3 equal parts. So 1/3 of the blood that is being pumped by the heart goes to Mr. Encephal, brain. 1/3 of the blood goes to your kidneys. And the remaining last 1/3 is for all other structures. That's how it's normally being distributed. But at any time, 2/3 of your blood volume is going to be within the veins and 1/3 within the arteries. Okay, guys, now I don't know what did they show that, because that's one of my favorites. Hold on. Do we have a picture of that one? Okay, yeah, okay, that's why. Okay, you missed that one. Sorry, guys. That was my mistake. Maybe I was a little bit too eager to get onto the popliteal pulse. But here, this is going to be your carotid pulse. Okay, that's going to be your carotid pulse. Now here's they probably went a little bit, you can say it's too far onto the side. So literally, guys, it's the ideal area for the carotid pulse is going to be between the thyroid cartilage, which is here. And what do we call this big muscle? That's why it's my favorite.
Is it the sternocleidomastoid?
Sternocleidomastoid. So pretty much, okay, an angle between your thyroid cartilage and the medial border of the sternocleidomastoid. That's going to be as okay where you'll find your carotid artery or common carotid. Clear? Okay. So yes, okay, guys. If you go, you can say carotid, temporal, brachial, radial, ulnar, femoral, popliteal, dorsalis pedis, and posterior tibialis. Right? Temporal, okay. Carotid, temporal, brachial, ulnar, radial, femoral, popliteal, posterior tibialis, and dorsalis pedis. These were all arterial pulses. Clear? Okay. Now, some of you may say, but okay, Mike, didn't you say that the arteries are deep? Which means, okay, buried down deep in the tissues. So how are we able to just, okay, feel the pulses or feel the arteries? And that's me as okay, that's why it's okay, these specific areas here is okay, has been, you can say it's okay, designated to palpate or feel these specific pulses, because that's where they mainly is okay. They can mainly says okay between that's okay what's going to be your fingers, and okay as another side of the artery is going to be as okay some more or less okay solid structure that okay make that okay even though you press on the artery as okay it's going to just okay have no room to just okay pass further down, but okay it's going to be not say trapped, but it's okay. But you mean as okay, we'll feel it in areas okay where there is going to be as okay structure below the artery. The mean as okay support in the way that okay when you put your fingers on it, that okay yes, and press on the artery, that okay yes, when it expands, that's okay, you will feel that expansion. Otherwise, you can say okay, doesn't the brachial artery run all the way like this? But here, yes, okay, and the anterior medial part of the elbow, that's where mean it's okay comes a little bit more superficial. Or you can mean it's okay the big bones of your elbow joints here, for instance, okay, forms as okay a lower support or a deeper support to the artery, and okay as when you press up against it, you mean it's okay feel that okay as it taps like this. Did that make any sense? So a little bit as okay mouthful about the arteries. Okay. Now guys, I once prepared this, okay, a long time ago, but it's okay. It is still going to be valid. Okay, so here's mainly as okay, just the names of is okay your different pulses. Okay, so brachial, radial, ulnar, temporal, carotid, femoral, popliteal, posterior tibialis, and dorsalis pedis. Oh yes, okay. If we look, yeah, I'm sharing this for you guys. Okay, and please keep in mind that these are all arterial pulses. Clear? Okay. Some diagram you can say is okay, carotid, temporal, brachial. Here we have the radial R pulse. Medial is going to be the ulnar, femoral, popliteal, dorsalis pedis, and here is going to be the posterior tibialis. Or yes, okay, we may say here, radial pulse. This would be ulnar pulse. This would be brachial pulse, carotid pulse, femoral pulse, popliteal pulse, dorsalis, posterior tibialis, and dorsalis pedis. So how did the pulse go?
I just have a question to what you said about the 1/3 of blood being pumped goes from the head, kidneys, and other structures. Was that
No,
the
what I
sequence?
said was if you now 2/3 of your blood volume at all time is going to be in the veins. So right now, it's okay, though you are sitting down, let's say that, okay, as your total blood volume is 6 liters. 4 of those 6 liters of the blood is going to be as okay in the veins. And the 1/3 is going to, which is going to be 2 liters, is going to be in the arteries. Clear? Okay. Which may or may as okay be in your arterial system to supply the organs. Now, when we talk about arterial supply to organs, okay, 1/3 of the blood in your arterial system, most likely right now, 1/3 of it's going to go to brain, 1/3 to the kidney, and the remaining 1/3 all other organs. Did that make sense? Now, of course, my idea is, okay, now when you go on your lunch break and you eat your lunch, that distribution, yes, okay, is going to be, yes, okay, changed a little bit. Because, okay, once you eat lunch, what's going to happen? Well, okay, now it's your stomach that's going to be working more, right? So at that point, you can mainly say, okay, some of the blood that might have been going, should have been going to the brain, will not be redirect from the brain to the stomach. Not all of it, but some of it. Okay, and that's why, yes, okay, you may feel a little bit dozy or feeling, okay, yes, should I take a nap or something like that? Or just chill? But generally, as okay, right now sitting here, not just okay, not have had okay as a happy meal yet. This is the distribution of blood. Okay. Good. Any questions? Okay, guys, so what I would like you guys to be sure that you know what's a pulse, what causes a pulse, what do you mean by pulse rate, What are the normal pulse rates? What do we call it? Yes, okay, when you don't have a normal pulse rate. Clear, okay. Either slow or fast. What can cause those? I can increase your pulse rate right now from, yes, okay, 73 beats per minute to 173 beats per minute. Right, okay. I'm not going to do it, but you know what I'm talking about, right? Okay. Yeah, okay. So that may cause it. Okay. What do you mean? Yes, okay. So what do you mean by rhythm? What are the types of rhythm? Now you have a regular rhythm, that's when everything is running smooth. Tung, 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 tung. You may have, yes, okay, irregular rhythms. Okay. Now when we say irregular rhythm, it's going to be tung, 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 whatever. Clear? Okay. Where, yes, okay, your rhythm is not regular. Okay. Did that make sense? So irregular rhythms can also be referred to as arrhythmia or dysrhythmia. Okay. Then yes, okay, what I just call is okay, the nature of the pulse. You can say, okay, strong pulse. Good, no problems with that. That's the way we like it. Okay, it's going to be more of an issue if you say as okay, weak or steady pulse, because that mainly will mean stroke volume will be low. When stroke volume is low, automatically, yes, okay, cardiac output will be low. And you may, yes, okay, will have a poor circulation of blood, which mainly will mean that the organs in the body will not get the blood that they may need. Did that make sense? Okay, and that's called, yes, okay, and that's when, yes, okay, your body organs are going to, yes, okay, start acting crazy. Just think of it. You're being used to begin with, okay, 2 pieces of chocolate every day, or candies, or okay, as ice creams or whatever. And one day I say, well, okay, listen, dear, today no ice cream. How will you react as a person?
Be sad.
Be sad. Okay. If we talked about it's okay when you were 3 years or 4 years old, what will your reaction be?
Tantrum and cry.
Tantrums, right? Okay, cry, rubbing, yes, okay, you heal. I want my ice cream, right? So just think of your organs, yes, okay, start, yes, okay, acting the same way. Okay. Or you may say, okay, I need my 2 ice creams to be as okay, able to function properly, right? So yes, okay, if organs don't get the blood that they need, well, okay, something is going to happen with how they function. That's what you call clinical signs. Okay, ladies and gentlemen, so good. Let me send you guys on a lunch break, and when we come back, yes, okay, you will, we can talk a bit about blood pressure. Okay, so would it be fair that I see you guys back at 1 o'clock?
Sounds good.
Sounds good? Goody buddy. Enjoy till then, yeah. Nope, nothing. Okay. Good. So our next vital sign is going to be what we call the blood pressure. Okay. Now, ladies and gentlemen, usually when people talk or mention the word blood pressure, they may say, I have blood pressure. What would that mean? If somebody walks up to you and say, I have blood pressure, what are they talking about?
Well, doesn't everyone have a blood pressure? It's either high or
Okay.
low.
Okay, but usually when people walk up and probably not on the street, but it's okay if you hear somebody say it's okay that I have blood pressure. What they most likely is okay may be referring to is a high blood pressure. But it's okay, Justine, you're right. Everybody has a blood pressure. Okay. If you didn't have blood pressure, then you were in trouble. Clear? Okay. So everybody has blood pressure. Or let's say it's everybody has a blood pressure. Clear? Okay. So usually when people talk of, okay, I have blood pressure, they mainly as okay refers to as having a high blood pressure. And that high blood pressure is what we as okay clinically or technically is okay refer to as a hypertension or high blood pressure. Okay. Now, guys, how do we define blood pressure? Okay. Now, ideally, it's okay when we take a blood pressure or when we record a blood pressure or the blood pressure that we take that we actually is okay, we'll end up documenting as the patient's blood pressure is going to be the pressure of the blood in the arteries. Is that clear? Okay, so we can mainly say, okay, what is going to be a blood pressure? That's going to be the pressure that the blood applies onto the vessel walls or to the walls of the artery as it flows through the arteries. Clear? Okay. Or we can say the pressure that the blood exerts onto the arterial wall is the blood pressure. Okay, which means it will be the pressure of blood as it flows through the blood vessels. For our case here is going to be okay, the arteries. Did you guys get that? Okay, so what is that the blood pressure is going to be? Is going to be more of a numerical figure that's going to okay give us an idea of the blood flow through the arteries. Okay, but mainly it's okay focusing on how much pressure does that blood apply onto the arterial walls as it is flowing through the artery. Okay. Now, usually, guys, that's okay when talking of how to document a blood pressure. Okay. Now it's very straightforward. Okay, it's going to be very straightforward. Keep in mind that you have to have a solid grasp of what we mean by systole and what we mean by diastole. Okay, so you can mainly say that, okay, yes, your blood pressure is going to be documented as a fraction. Okay, now when I say fraction, that will mainly mean that, okay, yes, a number above the line and a number below the line. Okay, but it's not going to be an actual fraction. Okay, now the number above the line, generally, it's okay, is what we refer to as a nominator. And as the number below the line is going to be the denominator. Okay, but when we write a blood pressure, the numerator is going to be your systolic blood pressure. Clear? Okay. Now, why do we call it the systolic blood pressure? Because that's going to be the pressure of blood in the arteries during systole. And when we say systole here, it's okay, we are talking about the systole of the heart. And what happened during systole of the heart? That was mainly, it's okay, when you can say it's okay, a chamber of the heart would contract. Mainly, it's okay, our main chamber of interest in this case here is going to be the ventricles. Did you guys get that? Okay, so when the ventricles contract, what's going to happen as a result of that? A big or small amount of blood is going to be pushed from the ventricles into the arteries. And as that blood flows through the artery, it's going to exert a pressure up against the arterial wall. And that pressure by the blood is going to be referred to as the blood pressure. Okay, so you will mainly see that the top number, or the numerator as we call it, or what here means, okay, is going to be referred to as the systolic blood pressure. It's always going to be the greater number. Okay, so any person, yes, okay, whose blood pressure is being read or recorded, the systolic blood pressure is always going to be greater. That makes sense. Now your denominator, the number that's going to be written below the line, is going to be associated diastolic blood pressure. Okay. Now, ladies and gentlemen, please keep in mind that, okay, yes, even though it's okay, the heart goes into diastole, even though it's okay, the heart chambers dilate, or we can here say it's okay, our chamber of interest is the ventricles dilate. That doesn't mean that the artery will completely collapse and there's no blood flow. Okay, the blood is still flowing, but mainly it's okay because it's a relatively lesser volume during the stage of diastole. That will be a lower pressure. So the bottom number, or the denominator, which mainly represents the diastolic blood pressure, is always going to be lower. And that's why you may see, as okay, somebody is okay, if you measure their blood pressure, you may get a reading of, let's say, 120 over 80, just a very normal blood pressure. Clear? Okay. But what does the 120 mean? That is going to be the systolic blood pressure. What would be the 80? That will be the diastolic blood pressure. Okay, so the top number of the systolic blood pressure is always going to be greater than the bottom number or the diastolic blood pressure. Did you guys get that? Okay, now one thing, okay, yes, and I have these couple of slides here. that means yes, okay, we'll just send out to you guys. But as well, so you most likely yes, okay, will receive them in your email. Okay. Yeah, here we go. Okay. So usually it's okay when we talk about yes, okay, measured things and okay, as which were represented by numbers. We can say it's okay, there may be as okay a normal range. Okay, so a normal range of blood pressure is going to be as okay as long as it is the systolic is between 90 and 120. Okay, as long as your systolic is between 90 and 120. That's going to be as okay a normal systolic blood pressure. Whereas on the other hand, you can say, it's okay, as long as your diastolic blood pressure is going to be between 60 and 80, that will be a normal blood pressure. Okay, so that will be only as okay be the lower range. As okay, we can say as okay the normal range. Now, what we see here is what you as okay will call low blood pressure, or what we can call a hypotension. Okay, now, ladies and gentlemen, please remember that for a blood pressure, for a blood pressure to be high or low, or to be considered to be high or low, it's not necessary that both of the numbers have to be high or both of the numbers have to be low. Even if one of them is high, you have high blood pressure, whether it's the systolic or whether it is the diastolic. Did that make sense? Okay. Okay. So usually it's okay back home. I don't know where they got that perception from, but you would tell a patient, are you aware that you have high blood pressure? And you go, yeah, my doctor told me I have a high blood pressure, but my lower pressure is normal. What they mainly as okay meant by the lower number is that the diastolic pressure was normal. That fall in the was still within that normal range. It was the systolic pressure that was high. And that's the dangerous one. Okay. And they were walking around like, okay, like in Hakuna Matata mode, right? Okay. Like, okay, nothing. Not knowing that actually it's okay, they were sitting on a ticking time bomb. Okay. So please keep in mind, guys, that it doesn't necessarily have to be both numbers that are going to be high for your blood pressure to be high. Even if one of the two is high, you will have a high blood pressure. But what they mainly will say is, okay, if your systolic blood, or if a person's systolic blood pressure here, guys, is lower than 90. If the systolic blood pressure is lower than 90, he or she is okay, will have low blood pressure, or what we call hypotension. Okay. Even if his or her diastolic blood pressure is less than 60, it's going to be hypotension or low blood pressure. Did you guys get that? Good. Then there's this phase that we call is okay pre-hypertension. Okay, and as long as okay, yes, your blood pressure or systolic blood pressure is anything between 120 to 140. Please keep in mind, it's okay, blood pressures can't be odd numbers. Okay, there's a metric reason behind that. Okay. Okay. So pre-hypertension. If the systolic pressure is 20, 122, 140, or the diastolic is anything between 80 to 90. The patient is in that phase that they clinically as okay label as hypertension. Oh, sorry, pre-hypertension. The patient is not clinically as okay diagnosed as being hypertensive yet, but as okay, the thing can go in any direction. Most likely as okay, if they don't take care of it, tuck, 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 it's very likely that okay, as he or she as okay ends up getting hypertensive. Okay, now when we talk hypertension, that's going to be as okay once you cross the line, but there's going to be two stages. One where it says okay, stage 1. Well, okay, as hypertension is hypertension, but it says okay, relatively mild hypertension, if you want to put it that way. It is okay as if the systolic pressure was 140 to 60, 160, or as okay, the diastolic blood pressure was anything between 90 to 99, 100. Okay, that may mean okay, the patient has hypertension, but here's okay, he or she is in what you can call stage 1. Stage 2, if the systolic blood pressure is more than 160, or the diastolic blood pressure is more than 100. And practically speaking, yes, okay, a person who is in stage 2, and you see, yes, okay, there's no upper limit. Okay, so stage 2, that is clinically alarming. That's emergency situations. Okay, that patient shouldn't be walking around, even if he or she is on blood pressure medications. Okay, that medication or treatment needs to be revised because it's probably not doing its job. Okay, so that's okay. Those stage 2 hypertensions, that's okay. They are actually, that's okay, life-threatening. The greatest risk is that the patient is okay, may suffer a stroke at any time. Did you guys get that? Okay. Strange enough, that's okay, the patient may already have suffered a stroke. Now, hopefully, that's okay, you're not going to see those patients, but that's okay, patients who suffer a stroke, the blood pressure is, or at least that's okay, the recording of the blood pressure is going to be abnormally high. Okay. And a reason is that, okay, as the brain is not able to register the blood pressure. So, any questions? Okay. Now our thing comes, how in the blue do we know how to record the systolic blood pressure, how to record the diastolic blood pressure? Or when we will know that, okay, now our reading is systolic blood pressure and now our reading is diastolic blood pressure. Okay. Now, one thing about blood pressure, it doesn't really matter which type of equipment that you use. Whereas the old traditional mercury manometers, whereas the more updated is okay, Aeronaut manometers, those big bends or smaller, bigger clocks, or yes, okay, if it is a digital manometer. The unit for yes, okay, blood pressure is measured in millimeters of mercury. Okay, so the standard unit that we use for blood pressure is going to be millimeters of mercury. Okay, you may see that, okay, as when blood pressure is documented, it's going to be mm. Now, mm is mainly, as okay, just the abbreviation for millimeters. Okay, And they're not going to ride off mercury. Okay, and here is okay, we're not talking about the planet Mercury. We are talking about the substance mercury. Okay, okay. So the clinical symbol, or the chemical symbol, sorry, for mercury is Hg. H as in happy, G as in good. Okay, where the H is going to be uppercase and the G is going to be lowercase. Okay, so Hg is the is the chemical symbol for mercury. So millimeters of mercury. Okay, although as I said, nowadays we do not use those mercury, or as okay, those manometers which contain as a tube in which a film of mercury is going to rise as the pressure increases. But we just so lazy that we didn't change the unit of blood pressure yet. Clear? Okay, so no matter which kind of equipment you use, it's always still going to be documented as a pressure, which is going to be millimeters of mercury. What did that mainly mean? That as the pressure actually was going to cause a film of mercury to rise this many millimeters. Any questions so far? Any questions? See. Okay, ladies and gentlemen. Now, so how do we measure blood pressure? Now, first of all, we say, we're going to, what are we going to measure? Well, when we talk about blood pressure, we're going to measure the arterial blood pressure. Did that make sense? Okay. So that mainly will mean that, yes, we will get, or we will actually, use or utilize an artery. Okay. In which, we will measure the blood pressure. Okay. Now, the common artery to be used to measure the blood pressure in is going to be your brachial artery. Did that make sense? Okay, so the common artery used to measure the blood pressure is going to be the brachial artery. Now, ladies and gentlemen, where do you find the brachial artery? Huh?
In your arm.
Upper arm, right?
Mhm.
Yeah, okay. Okay. Now it runs just in the entire course of the upper arm. Okay. But to be sure that yes, the chest piece of your stethoscope is on top of where you actually have the brachial artery. That's the reason that is going to be placed right here. Pretty much as at the point where you are able to feel the brachial pulse. Did you guys get that? Okay. So point number one is locate the areas where the brachial pulse is. In every person is going to be anterior medial to your antecubital fossa. When I say anterior medial, is going to be on the anterior side, more medially. So right here, I can feel my brachial pulse right here. Tomorrow, each of you can pay $3 and feel mine. It's just okay. You will feel a good brachial pulse, and I will get dirty rich. Is that clear? Okay. Now, next is okay. Yes, you will tie the cuff, or you will place the cuff around the upper arm. Now, ladies and gentlemen, looking at, okay, taking a blood pressure, yes, okay, you may say, okay, that looks pretty simple. Yes, it is. But it's a little bit scary that, okay, as it's been noticed or it's been seen that, let me not scare the shit out of you guys, but it's okay, up to, yes, okay, 60-65% of healthcare workers don't know how to take a blood pressure correctly. That's not me giving a number. It's not me giving a number. This is actually a number on hidden surveys or whatever you want to call it. Or somebody shadowing somebody who didn't know that they were being shadowed and checked on. Now, somebody may ask, how far up or low should I tie the cuff? So, ladies and gentlemen, I have a 2-finger rule. And what is my 2-finger rule? The lower end of your cuff should be just 2 fingers above the crease of your elbow. Okay, so that's going to be the placement of your cuff. So the lower border of your cuff is going to be at a width of 2 fingers above the crease of the elbow. Now comes just, okay, how tight or loose should we tie the cuff? Because can the cuff be tied too tight?
No, you won't get the accurate read.
Well, you will not get the actual reading, but can you tie it too tight to begin with?
No,
Yes, you can.
you can tie it tight.
You can tie it too tight.
No, I'm not saying it's not possible. I'm saying that it's not supposed to be like that. That's what I'm saying no to.
It's not supposed to be like that, right? Okay. So always go, how are you going to know whether it's too tight or too loose? That's the next thing of my 2-finger rule. Clear? Okay. So it should just be left so tight or just be left so loose that you only will be able to just, okay, put 2 distal digits of 2 fingers between the cuff and the skin or the upper arm. So if you are able to put, yes, okay, all 4 fingers like this between the cuff and the upper arm is too loose. Okay. If you hardly will be able to just, okay, snug just 2 digits like this of 2 fingers between the cuff and the upper arm is probably too tight. So that was my 2-finger rule. Clear? Okay, so where tie the cuff? Lower border of cuff. 2, that's okay, the width of 2 fingers above the elbow crease. How tight? Just so tight that only, yes, okay, 2 distal digits of 2 fingers, or yes, okay, 1 distal digit of 2 fingers can be snuck in between the cuff and the upper arm. Did you guys get that? Any questions? Good. What happens next? Have anybody ever get their blood pressure taken? I'm sure everybody, or somebody at least would. The next thing is, okay, that they will pump air into that cuff. Okay. For us, it's going to mainly as okay be compressing on this thing here, which is going to be the bulb. Now, yes, okay, with your bulb, you're going to have, yes, okay, let's just make this a little bit bigger. There's going to be a valve. And most likely, yes, okay, tomorrow, guys, I will show you, yes, okay, how you know that this valve here is closed. So that air that you puff by pressing on the bulb actually is okay, will fill up the cuff. Because, okay, you can push on this bulb here as much as you want. And, okay, as the cuff is not going to inflate.
Well, I can't see
Sorry, we
anything.
can't
Are you
see it.
showing us?
You can't, okay, sorry, guys. Thanks for letting me know. That's, sorry. Sorry. Okay. You should be able to see now. Is that better?
Yeah, we can see the screen.
Okay. Well, you could see a screen before too, but probably not the right one. So, ladies and gentlemen, this is going to be as okay your bulb. Okay. Most likely as okay, right next to this bulb is going to be as okay what we'll call a valve. Okay. Now, that valve is okay, mainly is okay, will need to be shut or closed. And what is that going to do? Mainly is okay, just cause that okay, whatever air we pump through the tube here is okay, mainly is going to go into the cuff, but not be able to come back. So what's going to happen is that the cuff is going to inflate. And what would that do? That will pretty much increase the pressure inside the cuff. Okay. Now, when we intend to, as okay, for instance, okay, release that pressure, that's when the valve is going to be opened. And you mainly, as okay, will sense that, okay, the patient may feel, okay, that the cuff is actually, is okay, getting less and less and less and less and less tight. Okay. Because, okay, the pressure within the cuff is falling. Okay. And you may see that, okay, the pointer in this case is, okay, which is your Big Ben, is that's okay, going to move down from a bigger numbers, yes, okay, to a smaller number. Okay. Now, ladies and gentlemen, the actual pressure that we are measuring here is going to be, as okay, the pressure inside the cuff. Okay, it's going to be the pressure inside the cuff. Now, just think of a tug of war. Or you can say it's okay, arm wrestling. Now, you increase the pressure in the cuff. Mainly is okay by pumping air into the cuff, and the cuff distance, mainly is okay, put more and more pressure up against the upper arm of the patient. Did that make sense? Okay. Now there's going to be a point. There's going to be a point where the pressure inside the cuff is greater than the maximum pressure of blood in the artery. Did that make sense? Okay. Okay. So mainly as okay, just think of it that okay, as two people standing on either side of a door and pushing on that door. Who's going to be the winner here? If one person is standing inside the classroom and another person is standing outside the classroom and pushing up against the door, who is going to be the winner?
Door.
Why the door?
If two things are pushing up against each other.
No. Two people are standing on each side of the door and pushing. against the door?
The stronger
Who's going to
person.
be, huh?
The stronger person.
The stronger one.
Oh,
Right. Okay. Okay. So when your medical says, okay, that okay, when the pressure inside your cuff is greater than the pressure of the blood in the artery, or let's say, okay, the maximum pressure inside the artery, what is going to happen? Okay, the artery pretty much is going to be as okay, compressed or occluded as a result of okay that pressure of the cuff. Okay, and at that point, as okay, pretty much okay as there will be no flow in the artery. Did you guys get that? Okay. Now what will happen, or what you will need to do is release the valve. Or slightly, yes, okay, open the valve. And what is that going to cause? That air actually is okay, now is going to flow out of the cuff. And okay, the pressure inside the cuff is now going to get lesser and lesser and lesser and lesser and lesser. Now, at some point, there will be an instance, yes, okay, where you can say that the pressure in the cuff that you actually, yes, okay, see on the Big Ben and the maximum pressure in the artery are equal. And that's where you mainly say, yes, okay, that the blood is now going to start to flow in the artery. Did you guys get that? Okay. And here, yes, okay, you have your chest piece or the stethoscope on top of the artery and the earpiece is in your ear. And what you will start hearing at that pressure is going to be, you will start hearing a sound. Okay. It mainly has, okay, sound like a rustling, blowing sound. So the reading at which that sound, you start hearing that sound, that is going to be as okay, the max pressure of the blood in the artery, which will be your systolic blood pressure. So pretty much okay, the point or the pressure at which the sound will start hearing is okay, that sound, that reading is going to be your systolic blood pressure. Did you guys get that? Now, as you keep on, as okay, slowly, gradually, as okay, deflate the cuff. The pressure in the cuff is going to just okay become lesser and lesser and lesser and lesser. And actually, it's okay, it's going to be a point where it's okay, that sound that you heard will stop. And please mind my words, guys. That sound got to stop and stop for good. That sound need to stop and stop for good. That sound need to stop and stop for good. Okay? And the reading where you last heard the sound, that reading is going to be your diastolic blood pressure. Did you guys get that? Okay. Now you may then ask, so what was all the buzz about starting hearing the sound and the sound finishing? That's mainly because that's okay, the flow, or that's okay, the blood flows through the artery. But it flows again, that's okay, the resistance of the compressed artery due to the compression of the cuff. But there's some flow. Did you guys get that? Now, is there anybody who know what those sounds that we record when we record the blood pressure are called? No idea? No idea what this sound here is going to be referred to as? Okay, guys, they are called the Korotkov sounds. Who the blue Mr. Korotkov was? Let him rest in peace. But that's what they're called, okay? Okay, Korotkov. K-O-R-O-K. Okay, sorry. K-O-R-O-T-K-O-F-F. Korotkov sounds. K-O-R-O-T-K-O-F. So it's two F's, just like turning something off. Did you guys get that? Okay. Another thing. Now, now I said, yes, okay, ideally speaking, we use the brachial artery to measure the blood pressures, right? Or let's say, okay, arterial blood pressures. But don't we have arteries in other areas of the body where you could feel a pulse? Yes, guys. Good. Have any of you ever thought of just, okay, measuring a carotid arterial pressure? Huh? Now, don't do it. Don't do it the traditional way, okay, guys? Because what would that require?
Mercury?
Okay. Why mercury, my dear? So if I tell anybody else, okay, measure the patient's carotid arterial blood pressure, how is that not going to be practically possible?
Because you can't put the cuff around their neck.
If you put a cuff around somebody's neck and, okay, yes, fill it up here, what's going to be the next thing is you gotta, are you about to kill me or what? Okay. If somebody don't believe that, yes, okay, we can try that tomorrow as well. Who wants to volunteer for that? We tie the cuff around the neck and, okay, yes, inflate it. I don't think you will like it. Clear? Okay, so yes. Okay. But there may be instances, okay, where you can't measure the blood pressure in the arms. Why would that be the case?
If maybe if the person is too thin or maybe too overweight for the size of the cup. I know they have
No,
different
man.
sizes.
Okay, no, they have multiple sizes of cuffs.
I know. It's just it was a shock.
So that's fine. Okay, good.
When a patient has had breast cancer,
Very good. Why is that, my dear? Well, I know, but
really sure why. I just know that, that you can't do any type of blood, like you can't do anything off it. I just don't know why though. I'm just told
okay,
that.
my dear. Now, usually it's okay when patients have breast cancer. Okay. what the traditional practice was as okay, if they were, for instance, okay, to be treated for that, let's say as okay, mastectomy. Okay, now what I told you guys when we talked the lymphatic system was that a common area for yes, okay, breast cancer to yes, okay, primary yes, okay, metastasize to is the axillary lymph nodes. So usually it's okay, they will also take off the axillary lymph nodes. Okay, now what does that do? That mainly is okay, we can say it's okay, going to compromise of the lymphatic return from the arm. So generally speaking, it's okay, you will see that, okay, as somebody who may just have, okay, let's say, okay, one breast removed, for instance. Let's say it's okay, the right breast was removed, okay? That her right arm is going to be relatively, as okay, more swollen compared to the left. Okay, and that's pretty much okay due to, yes, okay, what you call lymphedema. Clear, okay? And now just put it in this way that, okay, now you try a cuff around the patient's arm and that's okay. Inflate that cuff. That's just going to put, okay, as an even greater pressure on the arm and actually it's okay, makes, in this case, it's okay, her lymphedema even worse. Did that make sense? Okay. Now, most like, okay. Yes,
I
my
just
dear.
have, is this just solely for women who, you know, who have mastectomies? It's not just like overall, everyone who has breast cancer, they can't have it's
Yeah.
only mastectomy. Okay. So it's
Mainly,
only
yes, okay.
Okay.
Relatively, yes, okay. Not necessarily only breast cancer because, okay, it may happen for somebody. It could be due to other reasons, but breast cancer is probably, okay, one of the most common ones, right? Okay. Where you may say, okay, well, okay, we can't use the right arm because of lymphedema. What is the common reason for lymphedema? Primarily because that the woman here had a mastectomy where they mainly as okay were also had taken most of the axillary lymph nodes as well, which means as okay compromises as okay the return of lymph.
Thank you.
No problem there. Okay, another case where okay as you may not use either arm is if somebody have what we call a AV fistula. Did we talk about that one? What an AV fistula was? A connection made between an artery and a vein. Okay. Now, why would somebody have something like that constructed? Because they were going for hemodialysis for kidney failure. Okay. Now, that arm on which usually that's okay because they make it on the arm. It's easily accessible. Okay, just roll up a sleeve and okay, as the fistula is right here. Okay, okay. So on the arm or on the limb where okay, as the person has an AV fistula, should not be used to take blood pressure. As a matter of fact, that should not be used to take blood as either. Because what do you do when they take blood? They tie that tourniquet around your arm, right? What is that going to do? Put a greater or increased pressure on your blood vessels. And that's mainly as okay what happens here. And that function in the AV fistula is okay may become dysfunctional. And now the patient is in a deep shit. And so maybe you. Because the patient may be due for his hemodialysis in 2 days. And they don't have a fistula now to perform it on. That's maybe as okay, the patient's lifeline that maybe it's okay enables the staff at the dialysis clinic to connect him or her to the dialysis machine. Did you guys get that? And you may see, yes, okay, a patient walking in, yes, okay, with, it may, yes, okay, it looks like, okay, bigger or smaller bumps on, yes, okay, both arms, and you say, oh, shit, which arm do I use? Usually, that's okay, the patient will say, okay, listen here, they always take it on the left arm, okay, because, okay, this fistula here is, okay, it's not working anymore. So, it's okay, if it's not working anymore, it's okay, you have no chance of destroying it. Clear, okay? But don't use my right arm. Did that make sense? Okay. Now, and that's it's a matter of if the patient won't be able to say, how would you know whether a fistula is working or not? Of course, you will have no idea. Two ways. Place your fingers right on top of the fistula. And what you will feel is a tremor or some sort of turbulence. That may mean that that fistula is functioning. Okay. If you're not able to hear or it's okay, feel, then the next thing you can do is listen. Now listen with the help of a stethoscope. And what you mean is, okay, we'll hear as you place the chest piece of your stethoscope on top of a AV fistula, that if it gives that similar sound or more of a rumbling sound. Yes. That will tell you that the fistula is working. Now, lucky for you guys who have cats, because what is it that a cat is going to be doing? He or she, it's usually a she, right? Okay, is going to be purring. How do you know that they are purring? You can feel that slight vibration. Clear? Okay. And what sound are you going to hear when you place the chest piece of your stethoscope on top of that fistula? It's going to be sounding like the sound of a purring cat. So who wants to bring that cat in tomorrow? So we can see, so we can hear and feel what a purring cat sounds like or feels like.
If I bring mine, you'll probably kick us both out.
Hurry up.
I said if I bring mine, you'll probably kick us both out.
No, I think we should keep Felix or Garfield out of this. It's probably going to be too much stress. But that's like, okay, the closest that you can actually, as okay, get to what it is, okay, it may sound like or feel like. So it feels like, okay, as a purring cat, and it sounds like a purring cat. Okay. People who, God forbid, as okay, if somebody is an amputee or as okay, was born with arms, and you have blood pressure to measure. Well, okay, as I said earlier, it's okay, don't go for the carotid one. There are other, it's okay, mathematical ways in which it's okay, the carotid blood pressure can be calculated, but that's calculations. Okay, you can always go for another artery. And most likely, it's okay, they will go for the popliteal artery. Clear? Did that make sense? And in that case, that's okay, you made it, okay, we just have to tie the cuff around the thigh. Did you guys get that? Okay, so tomorrow, guys, that's okay, we will talk a little bit more about the blood pressure. Okay, now what I would like to email you guys today is okay, those two PowerPoint slides and a little Word document. Mail is okay. Let's say it's okay. The notes or some notes that you may feel handy for your pulse. Okay. Some things, yes, okay, already I mentioned in your book, but something that I didn't, that you don't find in your book. But yes. Okay. So that's okay. I will forward that one to you as well. Okay. So you'll find those in your inboxes. Any questions?
So tomorrow, 9 a.m. at school. Are we meeting in the cafeteria or in the?
No, I just got an email. Good that you asked, my dear. I just got an email that's saying, okay, we are going to be in classroom number 1. I
Okay.
think that's the one right up by the administration.
Oh, okay.
Yeah. Okay. But if not, that's okay. I can always catch you guys in the cafeteria, and then I can walk you to the classroom. Anything else, guys? Yep. CC. Then okay, I guess we can finish off with okay as the remaining of our blood pressure tomorrow. Then maybe it's okay a few small points that I mean it's okay. Just want to supplement with, and let me go for that. Okay.
Thank you.
Any questions?
Thank you.
Yep. Okay, guys. Then have a blessed day. Enjoy the sun, and see you guys tomorrow.
Thank you. Have a
Thank
good
you.
night.
Okay, bye-bye.
you.
Bye-bye.
Good day.